The following podcast is part of a certified educational activity titled A Pharmacist's Take on Navigating the Expanding Therapeutic Landscape for Endometrial and Cervical Cancers. Insights on Coordinating and Delivering Effective Modern Care. Access the entire activity and complete the post-test at peerview.com/ZPE 860. Downloadable slides and practice aids are also available.
Hello, everyone, and welcome to A Pharmacist's Take on Navigating the Expanding Therapeutic Landscape for Endometrial and Cervical Cancers. My name is Sarah Hayward. I am a clinical pharmacy specialist in gynecologic oncology at the Citizen Cancer Center at OU Health in Oklahoma City, Oklahoma. Joining me today is Dr. Amber Khan, who is also a gynecologic oncology clinical pharmacy specialist, as she works at the James Cancer Hospital at Ohio State University in Columbus, Ohio. Amber, great to have you here today.
Thank you, Sarah. Glad to be a part of this educational activity and discuss the pharmacist's role in endometrial and cervical cancer care.
All right, with that, let's get started. Let's go over our goals for today. So at the end of this lecture, our goals are to have improved learner knowledge on the mechanisms of action of immune checkpoint inhibitors and to discuss the latest evidence supporting the use of immunotherapy in both endometrial and cervical cancers. We want to make sure that we gain insight into the importance of molecular testing in endometrial and cervical cancers and how this can impact patient treatments. We want to offer guidance to other pharmacists to develop collaborative practice strategies with the care team to address practical aspects of care, including staff education, patient counseling, adverse event management, and safety and dosing considerations. With that, we're going to get into a little bit about endometrial cancer and its overall incidence. So, as you can see here on this slide, overall in the United States, uterine cancer or endometrial cancer make up 3.4% of all new cases and 2.1% of all deaths. And this is for estimates for 2022. When we talk about endometrial cancer as a whole, at all the cancers, it comes in about 9th place most years. And when we discuss it in comparison to our other gynecologic malignancies, which would be ovarian and cervical, which we'll talk about in a moment, this is the most common gynecologic malignancy. That being said, it is also the one with the best overall 5-year survival. This is because with endometrial cancer, we often see it present in much earlier stages. Patients have symptoms such as postmenopausal bleeding, irregular bleeding, that bring them in to their doctor sooner rather than later, giving us those better survivals. Looking at cervical cancer, we can see here overall less than 1% of all new cases and deaths. If we compare it to all cancers in the United States, it comes in around 20th place for 2024. Now, this isn't the case when we talk about worldwide incidence. Unfortunately, based on the World Health Organization, cervical cancer is the 4th most common cancer in women worldwide and is more common in patients who are in low or middle income countries. We can also see here overall relative 5-year survival is pretty good. Again, similar to our endometrial cancer, we tend to see patients present with earlier stage disease because they are symptomatic, perhaps irregular bleeding, pain with intercourse, things of that. Also, depending on if they're getting regular screenings or not, this is important to overall survival. Something I want to touch on real quick is if we go back and look at these numbers in the early 2000s, you can see that overall incidence of cervical cancer is a little over 4% of all cases and about 2.5% of all deaths. Obviously, we've come a long way and much lower now. This is probably mostly in part due to HPV vaccine, which came out in 2006. Which we know is helpful in preventing long-term HPV infections, which leads to approximately 9% of our cervical cancers and other cancers as well. It's very important to talk about disparities in the cancer setting. When we talk about endometrial and cervical cancers, we are definitely seeing overall, regardless of race and ethnic background, an increase in endometrial cancers. This is most likely due to our increased incidence of obesity, which increases continuous estrogen exposure. But that being said, we still, back in the 90s and even through today, still see that there is a large burden on our Black population. We see a large proportion of those patients having increased rates and increased mortality because of this. Also, when we're looking at the cervical cancer setting, we see both Black and Hispanic patients tend to have overall worse mortality because of this. This is often due to decreased access to medical care, decreased access to screenings, to care, and potentially, involvement in just care overall in clinical trials. One of our learning objectives for today was to discuss molecular testing. This is very important, and per our guidelines, NCCN guidelines specifically, and all guidelines do recommend that patients who have a diagnosis of endometrial or cervical cancer get molecular testing of their tumor tissue to help guide us in therapy. What you're looking at here is some information from the Cancer Genome Atlas Research Network. And what this did was look at hundreds of different endometrial cancer samples and tease them out into 4 specific groups based on their genomic profile. And we can see those here. Just to go over those briefly, we have the POL-E mutations. This is the very, very top of our list. This also, not only can this information help guide our treatment, but it also gives us some knowledge about patients' most likely progression-free survival information. POL-E, hypermutated, ultramutated patients, high level of mutation in their genome and their cancer cells, represents about 5 to 10% of endometrial cancers. Interestingly enough and amazingly enough, these patients have best progression-free survival. That might not be what we would think when we see high levels of mutation, but the suspicion is that because of these high levels, these tumor cells are better noticed by the immune system, and therefore we have a better immune response, or the excessive mutations can lead to the inability of these tumor cells to proliferate. Our next group is going to be our mismatch repair deficient patient and our microsatellite unstable patient. We're going to talk about more of this on the next slide. This represents about 20 to 30% of our endometrial cancers. One of the groups in here would be our Lynch syndrome patients. So these are patients who have a hereditary predisposition to developing cancer, specifically endometrial, colon, and others. We can also see these as somatic mutations. Now, to touch on this, we often hear the terms germline and somatic. A germline mutation means it was present in the germ cell. That means you got it from your parents and you can pass it on to your offspring. It's inherent in every cell. Somatic is not the case. It developed once you became your own individual human being. It's generally specific to that tumor, and you cannot pass it on. Why is this important? Because if you have a germline mutation, this means other members of your family might, which would necessitate genetic counseling to better their outcomes as well. Next, we look at the majority of our endometrial cancer patients, which is this no specific molecular profile. These are generally endometrioid tumors, low-grade tumors. They often tend to be estrogen, progesterone positive, and they can also have some specific mutations that can help guide other therapies like PTEN mutations, PIK3CA, RAS, etc. And then we have our copy number high, or patients who have TP53 mutations, TP53 being a tumor suppressor gene. If we lose the ability to use that, can increase in cancer. Often these are serous or mixed histology, and unfortunately, these patients have overall worst outcomes in the endometrial cancer setting. To touch a little bit more on MMR and MSI and what that means. MMR stands for mismatch repair. This is a system that we have in our bodies that is there to help repair errors in DNA replication. Lots of bits of information that happen during DNA synthesis, duplication, and cell splitting. And so we have lots of systems in place to repair those. Unfortunately, some of those genes can become non-functional. We can see here MLH, PMS2, etc. These can lead to what's called mismatch repair deficiency, so the body's inability to make these DNA repairs. This can lead to a condition called microsatellite instability. Microsatellites are repeat stretches of DNA that are prone to errors, and normally we have the mismatch repair system to regulate and repair, but if that is deficient, we can get high levels of microsatellite instability. So the take-home point of this is mismatch repair deficiency is the cause of microsatellite instability. The presence of microsatellite instability represents phenotypic evidence that MMR is not functionally normal, so we have a deficiency. So they're kind of hand in hand. A quick overview of how immune checkpoint inhibitors work. Another goal of our therapy today to talk about how we've integrated immune checkpoint inhibitors into endometrial and cervical cancers. As we're aware, immune checkpoint inhibitors work to block the T cell inhibitory signals to remove the brake from the immune system. It's very much how I explain it to patients. I explain to them that it's different from chemotherapy. It doesn't directly act on the cancer cells, but what it does is help our immune system unmask the cancer cells so that they can recognize them as foreign and then rev up the immune system to help us fight the cancer. Something else that's important to know is we're seeing so much increase in immune checkpoint inhibitor use across all cancer disease sites. And not only as single agents, but also in combination with other monoclonal antibodies, targeted agents, and cytotoxic chemotherapy. The important takeaway, and why we're talking about all this molecular testing, is because we have improved responses with immune checkpoint inhibitors for patients who are mismatch repair deficient, who have high levels of microsatellite instability, who have high tumor mutational burdens. This helps us provide treatment. And then we want to talk about how we're going to incorporate the pharmacist into this whole picture, right? The pharmacist can be integrated part of the healthcare team. You work with the oncologist, you work with all the other staff in the clinic, the nurses, the navigators, the MAs, whoever that might be, to help our patients have a successful treatment experience and outcome, hopefully. So the approach and just an example of some things on how a pharmacist can integrate themselves into this workflow is helping to onboard and make newer therapeutics operational. This could be, EMR builds and things like that, making sure that everyone has education, making sure the patient has access to the medication. This could be with helping with prior authorizations or helping with patient assistance programs for those uninsured. Making sure that our staff and our care team are educated on these medications. And this is very important because oftentimes if the patient's calling in, your clinic nurse or whoever's doing triage, they're going to be the first person that's speaking to the patient. And so it's important to them to know what to ask and what to look for. Making sure that we have good patient and caregiver education, right? This is a pharmacist's bread and butter. Making sure they know what to expect, when to call. Medication therapy management. So looking at the big picture on a patient, not just their immune checkpoint inhibitor therapy or their cancer therapy, but other comorbidities and other medications used to treat those comorbidities. And then patient assessment and AE management. Once we start therapy, we have to follow the patient. We have to give them the best chance of success at making it through this therapy. Is it dose reductions? Is it more supportive care? Getting it what they need. So that concludes our introduction. I want to pass the baton to Amber. Amber, there's been a lot of advances in immunotherapy in the endometrial cancer space. Could you take us through some of these changes and developments?
Certainly. In the next segment, I'll be discussing how immunotherapy is changing the practice of endometrial cancer care, particularly focusing on the pharmacist's role in this evolving space. So, to provide some historical context before I start, for several years, the standard of care for first-line treatment of primary advanced or recurrent endometrial cancer was platinum-based doublet chemotherapy, primarily carboplatin and paclitaxel. But the long-term outcomes were poor. And there was no ideal treatment option for recurrent endometrial cancer following initial treatment. But now, with recent data, there is evidence for chemotherapy plus immunotherapy in the upfront setting, and immunotherapy either as a single agent or in combination with a tyrosine kinase inhibitor in the recurrent setting based on biomarker test results. Let's start off by looking at a patient case, which we will return to after we discuss some recent clinical data. So, a 65-year-old woman presented with a 3-month history of abnormal uterine bleeding. Physical exam revealed an enlarged uterus and tenderness upon palpation. The clinical workup revealed grade 3 endometrioid adenocarcinoma, stage 4B, so advanced stage, with a good performance status, an ECOG performance status of 0. So In developing a management plan for this patient, what are some important factors that the pharmacist should be considering? What patient-specific factors should a pharmacist take into account, thinking about biomarker testing, medical history, current medications? And really, what can the role of the pharmacist be for patient education and safety management? And how do we use clinical evidence to help our decision-making? So the role of the pharmacist can involve several different things. One is a pharmacist can have a role in coordinating any needed referrals. An example of this would be if we're considering an immunotherapy-based regimen for a patient with, say, a history of an autoimmune disorder on immunosuppressive medications. A pharmacist can look at the list of immunosuppressive medications and recommend perhaps closer follow-up with the patient's specialist while we're initiating an immunotherapy-based regimen. Monitoring adverse events. Pharmacists can use their knowledge of drug mechanisms of action and side effect profile of medications to help distinguish which drug in a regimen is most likely to be the culprit of a given adverse event. Oftentimes, regimens have 2 to 3 drugs, and it's important to know the potential side effect profile of each drug to know which drug should be dose reduced. Pharmacists can monitor labs each cycle to determine which drug in a regimen may need to be held or dose reduced based on a specific lab abnormality or clinical symptoms. And also, pharmacists can help educate patient and caregivers really about, again, the possible side effects of a regimen and also the possible timeline for the onset of side effects. The patients can also be counseled by a pharmacist on when to contact their healthcare team. Because again, early intervention can help manage toxicities and make the regimen more tolerable for patients. Pharmacists can also educate staff about new drugs and how to triage patient calls. For example, if there's a side effect that would need to be evaluated urgently. So as Sarah talked about, the Cancer Genome Atlas project really helped to stratify endometrial cancer based on molecular subtypes. And as I mentioned earlier, the backbone of first-line treatment for endometrial cancer, for advanced or recurrent endometrial cancer, has historically been platinum-based doublet chemotherapy. But recent research has really delved into how can we use this molecular profiling and biomarker testing to help improve outcomes. And there are several studies that are underway looking at integrating different drugs with different mechanisms of action and using them in populations with specific biomarker alterations. For example, patients with HER2 positive advanced or recurrent endometrial cancer, NRG GY26 is looking at chemotherapy with or without a HER2 targeting agent. Or GOG 3075 is looking at evaluating endocrine therapy plus or minus a CDK inhibitor in hormone receptor positive advanced or recurrent endometrial cancer. In the next few slides, we're going to talk about 2 large phase 3 studies, the RUBY trial and the NRG GY18 trial, that evaluated immunotherapy plus chemotherapy in the upfront setting in patients with advanced or recurrent endometrial cancer. So we know that chemotherapy in advanced endometrial cancer had poor long-term outcomes. So in thinking about how can we augment response, researchers thought about the mechanism of action of chemotherapy and adding something that could leverage the body's immune system to help fight the cancer. And that something was immunotherapy. So chemotherapy works by killing rapidly dividing cancer cells. And that ultimately helps to upregulate programmed death ligand PD-L1 on cancer cells. And immunotherapy works by blocking the binding of the PD-1 receptor on T cells to the PD-L1 ligand on tumor cells. And so when that interaction between the PD-1 receptor and the PD-L1 ligand is blocked by immunotherapy, the body's immune system is able to see the cancer cells and attack it. So when immunotherapy is combined with chemotherapy, the immunotherapy's ability to block the PD-1 receptor helps to harness the body's immune system response and attack the cancer cells. So the RUBY trial was a phase 3 trial that looked at immunotherapy plus chemotherapy as a frontline approach in endometrial cancer. It was a randomized, placebo-controlled, double-blind, multi-center trial that enrolled patients with primary, advanced, or recurrent endometrial cancer. All endometrial histologies, including carcinosarcoma, were allowed. 494 patients were enrolled and randomized in a 1-to-1 fashion of dostarlimab plus carboplatin paclitaxel given every 3 weeks up to 6 cycles, followed by dostarlimab maintenance given every 6 weeks for up to 3 years, versus the placebo arm. The primary endpoints of the RUBY trial were progression-free survival and overall survival. So the graph on the left shows the Kaplan-Meier curves of progression-free survival in the dMMR population. As you can see, dostarlimab plus chemotherapy provided a substantial progression-free survival benefit in the dMMR population with a hazard ratio of 0.28. If you look at the 1-year mark, the progression-free survival was approximately 70%, and at the 2-year mark was relatively stable. That progression-free survival benefit at 2 years really speaks to the durability of response with the addition of dostarlimab to chemotherapy followed by dostarlimab maintenance. Now looking at the right, and you can see this is the overall survival benefit in the dMMR population. And you can see dostarlimab plus chemotherapy arm provided a substantial overall survival benefit in the dMMR population with a hazard ratio of 0.32. So in July of 2023, based on the results of this trial, the FDA approved the combination of dostarlimab plus carboplatin and paclitaxel for primary, advanced endometrial or recurrent endometrial cancer that is mismatch repair deficient. The other phase 3 trial that provided insight about the use of immunotherapy plus chemotherapy in first-line treatment of advanced or recurrent endometrial cancer was NRG-GY18. GY18 was a randomized, double-blind, placebo-controlled, multi-center study that enrolled 810 patients. Again, it included patients with advanced stage endometrial cancer and recurrent endometrial cancer. Of note, the GY18 trial excluded patients with carcinosarcoma histology. The patients were stratified by their MMR status into the dMMR cohort or the pMMR cohort. And the primary endpoints were progression-free survival in the dMMR cohort and the progression-free survival in the pMMR cohort. In terms of regimen, the patients were randomized in a 1-to-1 fashion of pembrolizumab plus carboplatin paclitaxel given every 3 weeks for up to 6 cycles, followed by pembrolizumab every 6 weeks for up to 10 years versus the placebo arm. So as you can see, the graph on the left, the pembrolizumab plus chemotherapy arm provided a significant progression-free survival advantage as compared to the placebo arm with a hazard ratio of 0.3, which means that patients in the pembro plus chemotherapy arm had a 70% reduction in progression of their disease. Now looking on the right in the pMMR cohort, the median progression-free survival also favored the pembrolizumab plus chemotherapy arm in the pMMR cohort, with a median progression-free survival of 13.1 months versus 8.7 months in the placebo arm. So based on the results of the GY18 trial, pembrolizumab plus carboplatin paclitaxel followed by pembrolizumab maintenance is under priority review at the FDA. Although the overall survival data for GY18 is still immature, there's a favorable trend towards an overall survival benefit in the pembrolizumab plus chemotherapy arm in both the dMMR and the pMMR cohort. It's also important to note that there are other phase 3 trials looking at immunotherapy with an anti-PD-L1 checkpoint inhibitor plus chemotherapy, followed by a maintenance component in advanced or recurrent endometrial cancer. So the phase 3 ATTEND trial is evaluating atezolizumab, which is an anti-PD-L1 checkpoint inhibitor, plus chemotherapy, followed by atezolizumab maintenance therapy in the frontline setting. In the phase 3 trial, DUO-E is evaluating another anti-PD-L1 checkpoint inhibitor, durvalumab, plus chemotherapy, followed by durvalumab maintenance, plus or minus PARP inhibitor maintenance with olaparib. There are also ongoing trials looking to see if we can use immunotherapy alone or immunotherapy in combination with a tyrosine kinase inhibitor in the upfront setting versus a platinum doublet chemotherapy in advanced or recurrent endometrial cancer. So Keynote C93 and Dominica trials are evaluating the anti-PD-1 checkpoint inhibitors, either pembrolizumab or dostarlimab, versus chemotherapy as a first-line therapy. And LEAP-001 is looking at lenvatinib plus pembrolizumab versus chemotherapy in the upfront setting. So there's a lot of exciting research taking place right now, which may shift how we treat advanced or recurrent endometrial cancer. So switching gears, I just wanted to talk briefly about overall immune-related adverse event grading and management. So in terms of general management of immune-related adverse events, it's really important to require a common terminology to classify the adverse events. So utilizing CTCAE grading, essentially. So if a patient has a grade 1 immune-related adverse event, typically the recommendations are to manage symptomatically, but it does not require holding the immune checkpoint inhibitor. For a grade 2 immune-related adverse event, may require holding the immune checkpoint inhibitor, as well as initiating symptom management and potentially initiating steroids, but at a lower dose of 0.5 to 1 milligram per kilo per day. For a grade 3 immune-related adverse event, typically the recommendation is to hold the immune checkpoint inhibitor, either treatment delay or discontinuation. Potentially the patient may require hospitalization, a specialist referral. This would be a point where we would potentially initiate higher dose steroids. And if the patient doesn't respond after 48 to 72 hours of the higher dose steroids, potentially looking at steroid refractory treatment options, including things like infliximab. Typically for a grade 4 immune-related adverse event, that requires permanent discontinuation of the immune checkpoint inhibitor. So management of the immune-related adverse event really relies on the severity and the organ system that's involved. So early intervention is the key, especially for GI toxicity like colitis, dermatologic toxicity, or endocrinopathies. Early detection and intervention is critical to reduce complications. So based on existing clinical studies, most immune adverse events were reversible and can be managed by holding the immune checkpoint inhibitor or initiating steroids or appropriate supportive care. It's important when educating patients about immune-related adverse events that they can occur at any time after the first dose or even several months after their last dose. But however, there is some data to help describe the onset of some of the immune-mediated adverse events. For example, skin toxicity can happen earlier in the course of therapy within the first 4 to 6 weeks. Colitis can occur within 4 to 10 weeks of initiation of the immune checkpoint inhibitor. The onset of pneumonitis tends to start a bit later, after week 10, and endocrinopathy can occur almost any time after the first 1 to 2 cycles. And as you can see, nephritis tends to be an immune-related adverse event that happens later on in the course. So let's come back to our case. So our patient was diagnosed with grade 3 endometrial adenocarcinoma stage 4B. Her biomarker testing revealed proficient MMR status, HER2 negative, and the care team elects to initiate frontline pembrolizumab plus chemotherapy regimen. So why was this regimen selected? Well, we know from the results of GY18 that there was a progression-free survival benefit in patients in the pMMR cohort, and also a trend for overall survival benefit in the pMMR cohort. And so since this patient has a pMMR status, I believe this regimen would be an appropriate frontline option. And so how do we educate on dosing and schedule. Well, the pembrolizumab and chemotherapy will be administered every 3 weeks for 6 weeks, and then patient will likely have imaging. And after that, if everything looks okay on imaging, we'll likely go on to the maintenance phase where the patient can come in every 6 weeks to receive only the pembrolizumab. So when you're counseling patients, the first 6 cycles, when you're getting the 3-drug regimen, pembrolizumab, carboplatin, and paclitaxel, those tend to be longer days. Just the infusion of the drugs itself is about 4 to 5 hours. As opposed to when they are in the maintenance phase, they can return to clinic once every 6 weeks, and their infusion days are much shorter. The infusion time of the pembrolizumab itself is only 30 minutes. So there's a little bit of change for the logistics. In terms of education for immune-related adverse events, I usually tell patients that immunotherapy can affect any organ in the body, and it can cause inflammation. And so typically I start at the top and go all the way to the bottom, describing the different organ systems that can be affected, and explain the clinical symptoms that the patient may feel. So an example of that would be colitis, which is an inflammation in the colon, but what the symptom that the patient might feel is diarrhea. Similarly, I would describe pneumonitis, which is inflammation in the lining of the lung. But the symptom that the patient might feel is shortness of breath or a dry, hacking cough that they can't seem to shake that's not productive. And so how would we advise a patient if they experience colitis after 1 month of treatment? Well, I usually tell patients if you have more than 4 to 6 episodes of diarrhea in any 24-hour period, we would like a phone call. Please call us because we can then ask you questions. If a patient has more than 4 to 6 episodes of diarrhea, that's considered a grade 2. And so we'll likely want to send some type of infectious workup. And if that's negative, we're going to likely initiate steroids. And so again, early intervention and management is key to reducing complications. So until recently, the backbone of first-line treatment was mostly, as I mentioned, platinum doublet chemotherapy with carboplatin and paclitaxel. However, there was no standard second-line therapy and limited treatment options following platinum failure. In this scenario, single-agent chemotherapy in this setting had response rates of 20% or less. So in the second-line setting, immunotherapy really emerged as a game changer in the management of endometrial cancer. Single-agent immunotherapy was approved for dMMR patients with recurrent endometrial cancer based on the results of the Garnet and Keynote 158 trial. So in April of 2021, dostarlimab gained FDA approval in that setting, and in March 2022, pembrolizumab gained approval in that setting. So we know that 25 to 30% of endometrial cancers are deficient in MMR, which means approximately 70 to 75% of endometrial cancers are proficient MMR. So how do we treat our pMMR patients in the recurrent setting? So we needed to find a drug to add to immune checkpoint inhibitors in this setting. And the VEGF angiogenesis pathway is an important target to modulate T-cell response. So investigators looked at adding a tyrosine kinase inhibitor, lenvatinib, that also has VEGF inhibitor qualities, to pembrolizumab. And Keynote 146 was a phase 2 trial that included an endometrial cohort which showed activity of the combination of immune checkpoint inhibitor and TKI in recurrent endometrial cancer. So that set the stage for the phase 3 Keynote 775 trial. In advanced or recurrent endometrial cancer, patients were randomized to receive either lenvatinib 20 milligrams oral daily, or plus pembrolizumab 200 milligrams every 3 weeks, or physician's choice chemotherapy, either doxorubicin given every 3 weeks or weekly paclitaxel. And the progression-free survival, overall survival, and overall response rates were statistically significantly improved with the lenvatinib plus pembrolizumab versus chemotherapy at the primary analysis. So the median progression-free survival and median overall survival favored the lenvatinib pembrolizumab arm versus chemotherapy. Also, the overall response rate and median duration of response were higher in the lenvatinib pembrolizumab arm. So based on the results of Keynote 775, in July of 21, the FDA approved lenvatinib plus pembrolizumab combination for patients with advanced or recurrent endometrial cancer that are pMMR. So it's important to counsel patients when they're getting these combination regimens, because the immune checkpoint inhibitors can have a list of side effects as well as the TKIs, and then they can also have some overlapping toxicities. And so it's really important to counsel patients about the overlapping toxicities, because those are the toxicities that we really like a phone call about, so we can tease out which drug could be the culprit. So it's important to counsel patients about rash, diarrhea, increased LFTs, hypothyroid, and altered mental status. And so what's important to consider when you're deciding which drug to attribute the toxicity to, either the lenvatinib or pembrolizumab? So one thing to consider is the timing of the event, and the other is the severity of the event. So in terms of timing of the adverse event, lenvatinib has a shorter half-life. Its half-life is only about 28 hours, and it's dosed every day. Pembrolizumab has a much longer half-life, about 22 days, and it's dosed every 3 weeks. So the first step would be to hold the lenvatinib and see if the adverse event improves. Again, the other thing to consider is the severity of the adverse event. Is it life-threatening or rapidly progressing? Because then it's important to hold both drugs and potentially initiate steroids if we think it could be an immune-related adverse event. You can manage most toxicities of the lenvatinib pembrolizumab regimen through holding the lenvatinib, dose reducing the lenvatinib, and prompt initiation of supportive care or steroids if needed. So let's bring up another case. We have a 65-year-old patient with a good performance status who presents with grade 2 endometrioid adenocarcinoma with advanced stage 3C1. Her biomarker testing reveals she's proficient MMR, HER2 negative. She receives 6 cycles of carboplatin paclitaxel and subsequently progresses after 4 months. So what are some treatment options in this setting? Well, with such a short disease-free interval, 4 months after her primary carboplatin paclitaxel, we'd want to look at a regimen with a different mechanism of action. And since the patient is pMMR, well, based on the results of Keynote 775, I would recommend lenvatinib pembrolizumab as a standard of care option. But we could also think about clinical trials of this patient. Assuming that the patient is placed on lenvatinib pembrolizumab, how would we counsel the patient on dosing? Well, lenvatinib is dosed 20 milligrams by mouth every day. The patient should take it approximately the same time every day, and it can be taken with or without food. I always tell the patients that lenvatinib comes as 10 milligram capsules, and so they'll have to take 2 capsules once a day. And for the pembrolizumab, the IV infusion, they'll need to return to the clinic every 3 weeks. In terms of side effects of lenvatinib, I do counsel patients on the risk of hypertension and ask if they have a blood pressure cuff at home. We ask that the patients monitor their blood pressures twice a day on lenvatinib, and to call our office if they have 2 blood pressure readings that are greater than 150/90, at least 30 minutes apart. So I counsel them also about the need for baseline EKG, the need to monitor their protein levels in their urine while they're on the lenvatinib, and obviously we check labs every cycle, so we're monitoring their counts and their chemistries. Also, it's important, again, to counsel patients on the overlapping toxicities, the diarrhea, the rash, the increased LFTs, or the thyroid dysfunction. And another important point to talk about with the patients when you're initiating pembrolizumab lenvatinib is a lenvatinib copay. Sometimes, even if insurance covers the lenvatinib, patients can have a high copay. And in this instance, sometimes we're able to approach the drug company to see if they will provide copay assistance for our patients. And sometimes this process of getting approval from the insurance company and the drug company can take up to a week or a week and a half. And so I always tell patients when we're starting on this regimen, sometimes there's a little lag in starting just to get you initiated. So we've reviewed a lot of approaches pharmacists can take for endometrial cancer. Sarah, can you talk us through some of the updates and strategies for the management of cervical cancer?
Absolutely. Thanks, Amber. That was a great overview of immune checkpoint inhibitors and endometrial cancer. In this next segment, we're going to talk about the pharmacist's perspective on the use of immunotherapy for cervical cancer. So let's begin with a patient case. Diana is a 68-year-old patient who presents with postmenopausal bleeding. Her last Pap test was over 10 years ago. Her physical exam shows that she has a large cervical mass, and subsequent imaging shows that she does have tumor invasion into the bladder. Clinical workup does confirm that she has stage 4A invasive squamous cell carcinoma of the cervix. So some things to think about as we look through the evidence are, what are our first steps in evaluating this patient for treatment selection, and how should the care team approach molecular profiling to guide therapeutic decisions? This slide that we're looking at shows a snippet of our guidelines for treatment of recurrent or metastatic cervical cancer. As we can see, in the setting of recurrent or metastatic disease at presentation, we do have the option of immune checkpoint inhibitors, specifically pembrolizumab. These are for tumors that are PD-L1 positive. We'll talk a little bit more about that on the next slide. But we can give pembro in conjunction with either cisplatin or carboplatin, plus paclitaxel, with or without bevacizumab, which prior to the addition of the pembrolizumab was our standard of care option for this patient population, was that same platinum doublet with or without bev. In this particular setting, these patients would carry on after their initial therapy with their triplet or quadruplet regimen, with maintenance therapy with their immune checkpoint, and with or without the bevacizumab. We recently have the addition of pembrolizumab to the frontline setting, specifically for our patients with stage 3 or 4A cervical cancer. This is given in conjunction with chemoradiation, so cisplatin in conjunction with daily radiation treatments, and we're going to look at that data as well. We also have the option in the cervical cancer setting of doing single agent immune checkpoint inhibitor, and this is depending on molecular markers. So again, why doing this molecular testing is pertinent and relevant and important for all of our patients with a cervical cancer diagnosis. This is a review, again, of the presentation of the cancer cell to the T cell and how it can deactivate the T cell. In the setting of metastatic or recurrent cervical cancer, for a patient to be eligible for an immune checkpoint inhibitor, they have to have PD-L1 testing. This is an IHC method, and patients are considered, in this particular setting, PD-L1 positive if they have a CPS score of at least 1 or greater. To do a little bit of math, exactly what CPS means stands for combined positive score. And so what this is this is looking at all of the cells on a particular pathological specimen of tumor that stain positive for PD-L1 divided by all the viable cells present. To do some easy math, let's say we had 100 cells and we stain it, and one of those cells stains positive for PD-L1. That patient now has a CPS score of 1, which qualifies them for immune checkpoint inhibitors. We also need to do testing for microsatellite instability, tumor mutational burden, which we can do with assorted next-generation sequencing to help us determine if a patient is going to qualify, if they have unresectable disease, for a single agent PD-1 target or PD-L1 target. Jumping into some of our data. Phase 3 Keynote 826. This is what got us the approval of the use of pembrolizumab with chemo with or without bev in the frontline setting for recurrent or metastatic cervical cancer. So you can see here the key eligibility criteria, also some of the stratification factors, and one that we're going to look at a little bit closer is the PD-L1 status. So patients were randomized 1-to-1 to get their platinum doublet with either cisplatin or carboplatin plus paclitaxel, and it was up to the investigator if they wanted to add in bevacizumab. The patient was then randomized to receive either pembrolizumab or placebo, and this was given for up to 6 cycles. After scans. It was determined if the patient was eligible to move into a maintenance phase in which they could carry on with pembrolizumab or their placebo, with or without bevacizumab, and the pembro for up to 35 cycles ends up being about 2 years. So let's see what the data showed us. So this original study came out and got its approval in 2021. We've had a recent 2023 update, and this is the data that we're looking at here. So this is our secondary endpoints of overall response rate and duration of response. And really, the across the board picture is we saw increased overall response rate and increased duration of response with our patients that received pembrolizumab with their chemo, with or without Bev, compared to placebo. The bigger group here that I like to point out is the patients that have a CPS score of greater than 10 or greater, is that we saw a significant increase in duration of response. Something else to think about, so we have these dividing up, just to give you some numbers, a little over 600 patients that were enrolled in this clinical trial, and about, I think it was 500 and so had a CPS score of greater than 1. So we're looking at almost 90% of the patients in this particular setting did have a positive CPS score as we considered that. And so that is why we got that particular approval for CPS of greater than or equal to 1. Some other things to summarize here. So looking at our primary endpoints of overall survival and progression-free survival, we saw benefit, again, across the board for those patients who received pembro with their chemotherapy with or without Bev compared to the placebo. Hazard ratio of 0.6 for overall survival for all groups, more or less, is our average. So definitely favors the use of pembrolizumab in the frontline setting for recurrent or metastatic cervical cancer for those patients who are PD-L1 positive, right? And some other things, safety profile overall, there was really no new safety signals, nothing new. Everything fell in line with the generally observed adverse events that we see with these chemotherapies, that we see with bevacizumab, that we see with our immune checkpoint inhibitors. So with all of this, in 2021, the FDA did give approval for patients to receive pembrolizumab in the metastatic or recurrent or persistent cervical cancer setting. Looking at our newest trial with immune checkpoint inhibitors in cervical cancer setting is Keynote A18. This is what we now have approval. We'll see on the next slide. We have pembrolizumab that was given with cisplatin and radiation therapy for patients with high-risk locally advanced cervical cancer. In our key eligibility criteria, we had a couple different groups that were teased out. We have patients with a various stage 1 and 2 cancers, and then also stage 3 and 4A. So this was not used in the metastatic setting or 4B, just as a by the way. So patients were randomized. Everybody got their cisplatin with external beam radiation therapy and brachytherapy, and they were either then randomized to receive pembrolizumab every 3 weeks or placebo for every 3 weeks, and then carrying on with pembro or placebo maintenance, changing to that every 6-week time frame that we can also give pembrolizumab under for about 15 cycles. So we're looking at about 2 years. So outcomes on this trial. What we see here is our progression-free survival and overall survival. It's quite obvious there. We can see that those patients who did receive pembro with their chemoradiation therapy did benefit from the addition of that pembro. Hazard ratio 0.7 in progression-free survival and 0.73 in our overall survival. Now, that being said, remember, we did look at groups of patients who had various stage 1 and 2 cervical cancers, but those did not get approved. We actually did not see an improvement in PFS or OS in that particular patient population. It did not favor the addition of pembrolizumab. And so in January, the FDA did approve the use of pembro in the upfront setting with chemoradiation for patients who have stage 3 or 4A cervical cancer. Looking at safety signals, again, there was nothing new really noted. It was the same safety signals that we see with cisplatin, the same safety signals that we see with pembrolizumab, same adverse event profile when we use these medications individually. Some other trials that are notable for the cervical cancer setting and immune checkpoint inhibitors is we can use pembro by itself is an option. And this is for patients who have recurrence of their disease. They can have a high tumor mutational burden. They can be considered MSI high or have that PD-L1 positivity. This information was given to us by the Keynote 158 study. We can also use nivolumab as a single agent, useful in certain circumstances. This was specifically for patients who are PD-L1 positive from the Checkmate 358 trial. Now, we have some new information that was just recently published from Checkmate 358 that is looking at the combination of nivolumab plus ipilimumab. So the first time that we are going to have the CTLA-4 inhibitor, which we know we use for, a lot in melanoma and some other settings. So we'll see what's to become of that. It looks like they just want to expand it and move beyond a phase 1-2 trial. So let's go back to our patient case and use the data that we just reviewed to help our patient, Diana. So Diana, if we remember, has been diagnosed with invasive squamous cell carcinoma of the cervix. She's stage 4A. Some other things to note, she is PD-L1 positive. She has a CPS of 20, and we're going to start her on cis-RT, so external beam radiation, followed by brachytherapy with pembrolizumab. And this is based on our data that we just reviewed from Keynote A18. So how would we plan to educate the patient and the care team members on this dosing and schedule? This one is pretty busy up front. If we think about cisplatin RT, right, we give patients cisplatin once a week while they're receiving their radiation therapy. At my particular institution, we do that 5 days a week in the outpatient setting. So we give them radiation therapy Monday through Friday. And that is kind of the big component of it. It's pretty overwhelming, especially if you live in a place where we have a fair number of rural patients, making arrangements for them to be able to come and get their therapy on a daily basis. I like to make calendars for patients to write it out. Some of us are very visual learners. So being able to see it on paper, on a calendar, and what's expected of them each day can be very helpful. I do remind them that once we get to that maintenance phase where it's just the pembrolizumab only, we're only seeing them every 3 to 6 weeks, and it's a much shorter infusion time, right? Cisplatin itself can be a fairly long infusion because of all the fluids that we give for kidney protection in that particular setting. So it's always nice to give them sort of the bigger picture to look forward to, that it won't be quite as intense as we move forward. Amber, any input you have on this particular setting for patients, or how you might approach education differently?
No, I agree. I think that it is a busy schedule, and letting them know that weekly they'll be getting their cisplatin, and then every 3 weeks during that same period, you'll get an extra drug with the pembrolizumab. And then when you shift on to maintenance therapy, again, yes, it'll be much more reasonable. But those first 5 to 6 weeks are going to be busy.
Yeah, they're very intense. So something else we want to talk about are unique safety considerations when we talk about the combination of overlapping chemoradiation with immune checkpoint inhibitors. As we saw in the trial, we didn't really see anything new or different that we don't already know about administering cisplatin to patients, about radiation therapy, and about immune checkpoint inhibitors. So I think, again, it's just making sure that we cover all of those basics with the patient in the setting of cisplatin, understanding about hydration, understanding about hydrating at home, understanding about nausea, vomiting control, letting them know that they're going to have an audiology appointment because they can have hearing toxicities with this, making sure that they know how often their labs are supposed to be and how that's going to change when we go from our initial into our later therapies. And again, as Amber mentioned in the last section, immune checkpoint inhibitors, that can be a lot to talk about, and it's important to tell a patient, it can affect any organ or tissue in your body. I like to focus on kind of what I call the big five, just for them to focus on. And then after that, anything strange or unusual, let us know. Better safe than sorry. Other AE management principles or factors that a pharmacist should consider or understand, like barriers to access or other disparities. As I kind of mentioned earlier, with this particular patient population, where I work, patients with cervical cancer tend to have less access to healthcare, might be more apt to be uninsured, might have lower health literacy. So it's important that you have a team approach to getting these patients the care they need. In a rural setting, they might live 2 hours away. So it isn't necessarily feasible for them to have to drive 4 hours every day to come get their radiation therapy. So making arrangements where we can, involving social work, involving navigators. For our underinsured, again, looking into patient assistance programs to make sure that they can get the care they need to prevent these disparities. And so something else to consider. So let's switch it up. We mentioned that this patient has a CPS of 20. Now, when we initially treated this patient, when she's 4A, we gave her cisplatin plus Pembro. The CPS isn't relevant. This wasn't really something that is required for these patients to get pembrolizumab in that frontline setting. But remember, in the metastatic setting, they do have to have that PD-L1 positivity. So, right, this is going to be our keynote study that looked at the addition of carbo, cis, Taxol with or without Bev plus pembrolizumab, which is every 3 weeks, which is nice for the patients. So we're not seeing them every day like we are with the cis-RT up front, but it's a lot to educate the patients on. You have lots of individual mechanisms of action that are happening and lots of different side effect profiles that can happen. So trying to keep in mind what your patient's education level is, maybe even their emotional setting when you have to go in and provide this information to them. Also, sometimes in this particular setting, we don't always have a CPS score immediately when it's time to start treatment. And so what we will do is we'll start patients on their cisplatin plus paclitaxel plus bevacizumab. And then once we have those results, which we do see CPS positivity in the majority of our cervical cancer patients with squamous cell specifically, then add the Pembro in later. Amber, do you have any input on that big 4 quadruplet regimen and educating patients in that setting?
Yeah, no, it can be a little overwhelming for them when we talk about each drug and their toxicities. And I think it'll be interesting to see how things tease out since we're giving immune checkpoint inhibitors up front. And should we be thinking about, different mechanisms of action when they recur? So like, is a tisotumab another option to consider, an antibody drug conjugate? So I think that there's a lot of unanswered questions about how to sequence things. So I think it'll be very interesting to see where things shake out since we're giving the immune checkpoint inhibitors up front now.
Absolutely. I think we're in a lot of settings wondering, then what do we do after that? So time will tell. So to wrap up, just as we're getting closer to the end, some things to consider from the pharmacist perspective and our involvement in checkpoint inhibitors, right? Making sure that we explain proper dosing and scheduling to the patient so they understand what the expectations are and when they need to see us and when we're going to see them. Making sure that we help with medication access that can absolutely be a barrier for certain patients. And so helping with prior approvals, making sure that we work with patient assistance programs to get them the things they need. Also, proper supportive care medications. Definitely in the setting when we're giving this in combination with cytotoxic chemotherapy so that they know what they need to use and where they can get it. Is it prescription? Is it over the counter? Can we use over the counter antidiarrheals in settings like that, and making sure they're well equipped to have the tools that they need and know when they need to call us. Education. Patient and caregiver education, very obvious, right? We want to make sure that they have a good grasp of the adverse effects that they can see, more common and less common. Having a high suspicion, because we can see all sorts of quirky things with immune checkpoint inhibitors as they can affect any organ and tissue in our body. Making sure that we encourage the patient to call us sooner rather than later. Share that we can nip these in the bud, even like when we're talking about a dermatologic toxicity, being able to catch it when it's on a small area and we can use topical versus when it spreads and we have to move to oral corticosteroids can become important. And then also making sure that our clinical staff is aware of side effects from these medications and how to answer patients' questions when they call, when they see them. Also, to be able to evaluate and know when we need to monitor and follow up. That is very important. So once we start these patients, we don't lose track of them, right? We want to make sure that we're getting proper lab follow-up. We're having proper follow-up in our clinic space, asking the right questions, because sometimes you have to prompt patients with the right questions so that they tell you the side effects. They might not think to tell you otherwise. Making sure that we assist with supportive care. So let's say we have a patient, they're on your immune checkpoint, they have an adverse event, we have to start them on 1 mg per kg oral prednisone. There's side effects with oral prednisone as well we have to keep in mind. Do they need pneumonia prophylaxis? Do we have to worry about them getting gastritis? Do we need, other things to consider to make sure that they're aware? Do we need to divide up the dose to make it a little bit easier for them to tolerate? This is a great place for a pharmacist. When it's time for a taper, pharmacists love coming up with tapers. We're really good at it. We like it. We know what strengths are available. Great way to incorporate yourself into the team and making sure we do that 4 to 6 week taper so we don't have a rebound of that adverse event. Also, collaborating with the care team. When can we restart? When can we not restart? What are we going to do to help this patient if we do restart, if it happens again? Things like that, all good things to consider. And as always, when we're talking about treatments in general, especially in the setting of oncology, clinical trials. It's so important to educate our patients and our staff about the importance to enrolling patients on clinical trials and getting them access. Why is this important? This is because clinical trials are the key step to getting translational research into medicine. This is how we can have better cures. This is how we can have better progression-free survivals. This is how we can even maybe have better quality of life with medications that might not be as toxic. These clinical trials can benefit not only the patient, as they might have improvement in their disease, but it can also benefit society as a whole. And that can be in a positive way, and that we know this new treatment is going to be better, or in the setting that we know we tried this and it didn't work, so we'll move on to the next thing. It's also very important that we think about diversity in clinical trial enrollment. In the U.S., the majority of our clinical trials, the majority of enrollment is in white patients. And so when we think about those disparities in care, we need to make sure that we're making an active effort to get all ethnic and racial backgrounds involved in the clinical trial setting to improve those outcomes for that patient population. Some takeaways, just to review back to our goal for the day. Biomarker testing is imperative for all these patients in endometrial and cervical cancer testing because this can dictate therapy. We have different issues that arise with immunotherapy and those various combinations. So making sure that we explain to the patient the distinct side effects that can happen with these individual medications. When we have a lot of overlapping side effects, like we can see with the setting of lenvatinib and pembrolizumab, trying to tease out and understand which one might be causing it. Amber, what else have we learned today?
Yeah, the importance of clinical trial enrollment for all patients, especially with a focus on increasing diversity, as well as we've mentioned it time and time again, but educating patients and their caregivers so they know what side effects may be possible and really when to call the healthcare team. So as pharmacists, you should be prepared, know how to answer some of these questions and where to direct queries.
Absolutely. So everyone, we want to thank you for joining us today and participating in this program. We hope that you had some great takeaways about approaches to immune checkpoint inhibitor use in endometrial and cervical cancer. And Amber, pleasure to work with you, and thanks for joining us today.
Thank you. It was great to be here. Please remember to download the practice aids associated with this educational activity as a resource for you, your staff, as well as your patients. And thanks again. We hope you found this activity informative and useful for your practice.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/ZPE 860. This activity is supported by an educational grant from Merck Co, Incorporated.